Okay, so I think we're going to go ahead and get started. Well, again, welcome to our first Graduate Scholars Conference. My name is Mike Putoff, and I'm the Dean of Graduate Studies. I'm excited to have this opportunity to highlight the work of a handful of our graduate students. We have 17 graduate programs at St. Ambrose, and about 20% of our overall student body is made up of graduate students. However, a lot of times we don't talk about what our graduate students are doing outside of each program, and we tend to become very siloed within our graduate programs. So we want to use this platform to share more of the great work being done across all of our graduate programs. So welcome to our faculty, staff, students who are joining us today, and those members of the community who have also decided to be a part of this event. Our graduate programs are recognized for their premier student-centered educational experiences. The programs build upon St. Ambrose University's Catholic liberal arts tradition and focus on the application of communication skills, critical thinking, intellectual inquiry, and creativity to professional practice. While each program is unique, our students leave St. Ambrose ready to enter new professions, advance in their careers, lead in their disciplines, and create new knowledge through research. Today is about highlighting some of the scholarly activities happening in our graduate programs. As you'll see, some of these projects are about the scholarship of discovery. Students have developed a research question, they conducted an experiment, and they've created new knowledge to add to their disciplines. Other presentations are about the scholarship of integration or the scholarship of application. Students conducted a critical appraisal or analysis of others' research projects and have applied this information to their own practice. Or they synthesized best practices in their disciplines and applied this information to real-world problems. So no matter the type of research done, these students are demonstrating the skills and critical thinking that's so important to our graduate education. Thank you and congratulations to all the students selected to present today. Now in a moment, we're going to begin with our first presenter. I want to go through a few housekeeping items. As we're all getting used to in these video conferences, I'm going to ask you to keep your microphone muted during the presentation. Each presenter has 8 minutes allotted to them to present. At about the 8-minute point, I'll step in and ask them to finish up just to make sure we stay on schedule, but I know they've practiced and they'll hit that mark. We will leave time at the end for questions, and there's a few ways you can ask questions. First, you can type your questions into the chat box, and when you do that, we would ask that you wait near the end to actually submit that question, or wait to the end of the presentation to type it out. Many times questions are raised during the presentation, but they're eventually answered near the end. So we want to cut down on some of the side conversations and chats going on in the chat box during the presentations so we can give the presenters our full attention. You can also raise your hand during the presentation using the raise your hand icon. I'll be able to see you and then I'll call on you, and as we've all done, make sure you unmute your microphone before you talk. You can also, during the question and answer, if no one's talking, feel free to unmute your microphone and just ask your question during that time. I would ask that you identify yourself before you ask the question, though. And then when we get to the end of each presentation, feel free to unmute your microphone and give our presenters a round of applause. Do know that we have 3 judges with us today. They're providing the presenters with some written feedback later on this week. We want this to be a great experience for you, the audience, but we also want this to be a great experience for our presenters to help them with their own professional growth and development. And we will be awarding some prizes to our presenters based on their presentation. So thank you to the judges for serving in this role. So with that being said, we're going to go ahead and get started. So how this will work, I'll give a short introduction of each presenter. They'll give you a little background on themselves as they see fit, and then they'll move on to their presentation. Okay, so our first presenter is Ambrose Solorzano. She's a Master of Public Health student. She'll be talking on bullying is more strongly associated with feelings always blue in girls than boys, the Rothman test for additive interaction. So I'm going to turn it over to Amberly, and she will share her screen with us and start her presentation.
Thank you. Hi, my name is Amberly. Sorry, just a second here. Let me just get this. Hello, my name is Amberly, and I'm an MPH student at the University of St. Ambrose. This abstract was written from a project I did in epidemiology, for which Dr. Colleen Doak was the professor. And the title of my abstract is Bullying is More Strongly Associated with Feeling Always Blue in Girls than in Boys, using Rothman's test for additive interaction. In the US, about 20% of school-age children report being bullied, either at school or on their way to or from school. And bullying can lead to outcomes in the long term, such as depression. In the United States public schools, gender-based bullying is the most prevalent form of bullying, and females are 1.5 to 3 times more likely to develop depression. So because of this, we're going to be looking at sex, being male or female, as an effect modifier, which is to ask, does sex modify the effect of bullying on the outcome of depression, or do sex and bullying interact? So the objective of the study is to ask, is the effect of bullying on depression-related outcomes stronger in girls versus boys? So we will be looking at this using 2 different methods. The first is a commonly used method in epidemiology, which is an interaction term in a binary logistic model. And then the second method is Rothman's test for additive interaction. This study, I used the longitudinal observational youth study. And this started in 1997, and I used the follow-up year of 2004. So the survey population was a little over 7,000 people born between 1980 and 1984 and made representative of the US. The questions that I used were, before you turned age 12, were you ever a victim of repeated bullying? Yes versus no. And then how much of the time during the last month have you felt downhearted and blue? All of the time versus most, some, or none of the time in the follow-up survey from 2004. For the results, for the crude and stratified results of the risk ratio, adolescents reporting having been bullied before the age of 12 in 1997 were 1.7 times more likely to report feeling always blue in the follow-up survey in 2004. And then down below is the confidence interval. So when this was stratified out or separated into sex of male and female, the risk ratio for males was 1.6 times more likely to report feeling always blue. And for females, it was 1.8 times more likely to be feeling always blue. And this analysis was done in our program and SPSS version 26. So is the effect of bullying different in females? This was tested using an interaction term and using a broad p-value of 0.20 to err on the side of including interaction. The formula shown below is a formula for logistic regression, which is a natural logarithmic function that is represented by the E in the equation. So here you can see the equation. The highlighted part is the interaction term, and Y stands for always blue, yes or no. X1 stands for bullying, yes or no. X2 stands for female, yes or no. And then X1 times X2 stands for bullying multiplied by being female, which is the interaction term that we are looking at. So down below that, you can see the equation with the numbers filled in. Again, the interaction term is highlighted, and the p-value was found for that interaction term. So the p-value was 0.75 for the interaction term, and that is greater than the p-value of 0.20, and so it is not statistically significant. So then we looked at this same information using the Rothman's test to see is the excess risk of being bullied in female greater than additive. So the first line here is the equation, which is RR11 minus 1, so that's the risk ratio minus 1, which is the equation for excess risk. So the first RR11 stands for bullied and female, the excess risk. And then we want to see if it's greater than or less than the excess risk, or RR10 minus 1, of being just bullied, or plus the excess risk of just being female, or RR01 minus 1. So down below that, the numbers are filled in. So the excess risk for being bullied and female is 2.2 minus 1. And then we want to see if it's greater or less than the excess risk of just being bullied, which is 1.6 minus 1, plus the excess risk of just being female, or 1.2 minus 1. And then down below are the results. So 1.2 was the excess risk for being bullied and female, and that is greater than the excess risk of just being bullied added to just being female, which is 0.8. So the excess risk of being bullied and female is greater than the excess risk of just being bullied plus the excess risk of just being female. So the interaction term was not statistically significant, but Rothman's test showed greater than additive interaction between being female and being bullied. So what we want to look at is this meaningful? Is there a difference between the stratified results of being male and female? The social stigma of men being depressed that could influence the results of the study, and because of this, men could be less likely to put feeling always blue on the survey. But females once they reach the age of 15, they're 2 times more susceptible to depression than males. And so this supports the results of Rothman's test. So Rothman's test for additive interaction contributes to the understanding of the results. I would just like to say thank you to the students in my Masters of Public Health program for their feedback, comments, and support on this project. And here are my references.
Okay, well, thank you, Amberly. We're going to open it up for some questions. While we're waiting for some to come in, I'll ask the first one of you, Amberly. How do the results of this contribute or reflect the current knowledge in the literature? Was this similar to other things you found in the literature? Was it a little different than other things? Could you talk about that a little bit?
I honestly, the more commonly used method to look at an interaction between 2 independent factors is the using the interaction term. And so I have not looked too much into the literature of using Rothman's test, but it is a less, it's not used as often. So this just shows that using Rothman's test can further analyze the results of a study.
Okay, thank you. Terry Schlebach has a question. So Terry, I'll let you go ahead and ask that.
Hi, Amberly. Very, very nice job. You used a secondary data analysis, and your database is somewhat dated. Is there a more recent one, and why did you choose that particular database?
Okay, so this was actually, this abstract was done as a project, initially as a project for my epi class. And so that was the year that I was assigned. The survey does go all the way up to 2018 for the latest follow-up with the group, but 2004 was the year that I was assigned for the project. So that's why I used that one.
Do you think it would have made a difference having a more recent, if you would have been assigned a more recent date?
In my opinion, I don't think that it would have made much of a difference with the research of females being more susceptible to depression than males.
Okay.
Thank you.
There's a quick question from Regina Matheson. Was there a significant difference between males 1.6 and females 1.8, or did you test this?
Yes, there was a difference between the two. There was a greater than additive difference between being female than being male, because when you look at Rothman's test, it being bullied and being female gives a greater chance that the person will report feeling always blue later on than if the participant was just male and not bullied.
Thank you. Monica Ford had a question of what number or percentage of males and females in the sample were bullied versus not bullied. I'm curious as to some of the basic descriptors, or descriptives, I should say.
That I don't have the percentage, but I have the risk ratio. Just a second here. Let me. So let me see here. So the total, sorry, I would have to get my calculator out.
Okay. Amberly, I don't think you need to calculate it. Maybe that's something you can get back into touch with Dr. Ford on, just so for time sake.
Yeah.
Okay, well, good. I know Dr. Scherer has a question, but we're at the 4-minute, a little bit past the 4-minute part for questions. So we're going to end this this part of the presentation. Great job, Amberly.
Thank you.
Great job, Amberly.
Thank you.
Okay. So Amberly, I'm going to ask you to stop sharing your screen, please.
Okay.
And then Anthony, you can go ahead and share your screen. So our next presenter is Anthony Peters. He is a Master of Science in Exercise Physiology student. He'll be speaking about the validation of the Garmin Forerunner 630 watches and predicting maximal oxygen uptake in hyperthermic training conditions. So I will turn it over to Anthony.
There we go. Can you guys hear me?
Yes, we can hear you now.
Okay, perfect. Thanks. All right. Hello, everyone. As I said before, my name is Anthony Peters. I'm a grad student for the Masters of Science in Exercise Physiology program here at Ambrose. Today, I'm going to present on my thesis, the validation of Garmin Forerunner 630 watches and predicting maximal oxygen uptake in hyperthermic training conditions. Sorry, it's a bit of a mouthful. As it freezes. Sorry, my computer's, there we go. All right, so here we used different activity trackers and associated them with their ability to predict VO2 max. So VO2 max, otherwise known as maximal oxygen uptake, it is the measurement associated with the maximal amount of oxygen an individual can use during intense bouts of exercise. In simpler terms, it is how much oxygen your heart can pump and how much of that oxygen your skeletal muscles can use. This measurement is associated, and this measurement is used to establish an individual's aerobic endurance and has been shown to correlate with endurance performance. Currently, activity trackers like Garmin are using algorithms to predict VO2 max based on running data gathered during training runs. Having this data readily available has led athletes, coaches, professionals, and fitness enthusiasts to take advantage and form entire training programs based on the predictions from these watches. We specifically use the Garmin Forerunner 630 GPS watch. This watch uses a combination of heart rate and running speed measures to predict VO2 max. So hyperthermic environment. A hyperthermic environment is essentially one of excess or elevated heat. For the purposes of this study, a hyperthermic environment was set as at or above 80 degrees Fahrenheit, i.e. summer, traveling somewhere. Either way, there's going to be an athlete that's going to be training in a condition like this. This kind of leads to a phenomenon known as cardiac drift. It's where heart rate drifts upward over time, paired with a continuous decline in stroke volume and maintenance of cardiac output. This event is observed occurring in times of increased core body temperature and water loss, like in our hyperthermic environment. In simpler terms, the body is hot, sweat and blood flow to the skin decreases, therefore blood ejecting from the heart decreases, so heart rate increases in order to compensate. This study sought to determine if the hyperthermic effect on heart rate is accounted for in the prediction of VO2 max by the Garmin device. So really, we developed this study to validate the effectiveness of the watches in predicting VO2 max in runners training in these hyperthermic hot environments. So we hypothesized that the Garmin watch's predictions for VO2 max in these hyperthermic environments would underpredict VO2 max when compared to the gold standard or indirect calorimetry during a graded exercise test due to this hyperthermic effect on training. Real quick, this is the participant characteristics, what we had to deal with. So what we had were college-age runners who at least ran 8 miles a week. So between age, height, and weight, that really made sense and didn't vary too much based on the population we were working with. What really varied the most was our weekly mileage. We had some people doing 8 miles a week. We had some people doing 70 miles a week. So it was a nice, healthy mix of runners. The actual study design was within Fahrenheit, again, that hyperthermic environment. For safety purposes, we had subjects refrain from runs that were really beyond this extreme caution range. So we did not want them in this orange or red range here. On the National Weather Service Heat Index, we just didn't deem it safe or necessary. So each one of these 5 sessions allowed the watch to learn and just take the different data for the prediction. Subjects logged outside temperatures through the actual Garmin Connect weather tracking function. This way we can go back and check and make sure they're in the ideal condition. We also had them keep a written log of each of these runs. This way we could look at the date of the run, how far, how long they did it, and the temperature, and go back to the actual Garmin Connect weather tracking function and everything. Make sure that they were within the parameters of the actual study. So from there, we had all of our subjects perform a modified bulky protocol in the exercise physiology lab. Essentially what that is we would increase the grade of the treadmill by 2% every 2 minutes until they reach volitional fatigue, all the while taking spirometry measures. As previous research has done, we assured that subjects met at least 3 of the following 4 criteria to ensure a valid test. So a plateau in VO2, respiratory exchange ratio of 1.1, heart rate 90% of the age predicted maximum heart rate or greater, and then a rating of perceived exertion above or equal to 18. So what we actually ended up finding here, we had the average predicted VO2 max, which is what the watch found, was a 50.9, along with the average measured VO2 max, gold standard in the lab, which was a 59, which can also be seen here on our graph. So from there, what we found was that the Garmin VO2 max was significantly lower than the lab measured VO2 max based on t-testing. We did also do a Pearson's correlations, which was 0.79, which indicated a strong correlation despite being significantly lower. More on that later. We also did do a Bland-Altman plot, our little graphic over here. Essentially what that's saying is that the Garmin displayed considerable deviations in scattering between 18.7 when compared to measured VO2 max in the lab. The Garmin also presented a tendency to underestimate with a bias of -8. This really further supported that exercise in the heat with the watch underpredicts VO2 max in the lab because all but one of our subjects ended up being underpredicted. This is really best portrayed by our blue zero line here and how that scattering looks from there. So what we ended up concluding is that the GPS watch worn in hyperthermic conditions significantly underpredicted VO2 max compared to a lab value. What does this mean? It means that when using similar fitness trackers, it really pays to be cautious of their results for research, training, etc., especially in these hyperthermic conditions. Again, we did also see a strong correlation. This makes it seem as if the watch can provide us some use to individuals seeking a simpler means to track their progress. It follows the same trend as the gold standard after all. However, this could only be true if the person is always training in the same level of hyperthermic environment. Otherwise, changes in VO2 could be from changes in the environment rather than changes in training. For example, you can get a valid max if you test 1 week in 90-degree temperature and another week in 90-degree temperature, but if you test 1 week in 90 and another in 60, you can't really say with certainty if you improved or if it was because of the change of that temperature, which is really why the prediction being off is a problem, especially for these people basing their entire training programs on these watches and their predictions. So yeah, that's really all I have for you guys today. Thank you for listening. If you have any questions, I'd be happy to answer them.
Okay, well, thank you very much, Anthony. We'll go ahead and open it up to questions that people might have. Okay, we got one that came through here in the chat from Dr. Lantis. Anthony, did you allow runners to consume fluid during training or ensure adequate hydration prior to training? Also, do you know the correlation of the watch in normal temperature, if the correlation of the watch in normal temperature was greater than 0.79?
So that was actually, that's a really good question. We kind of looked into that for our limitations. We did not track hydration status. It was kind of something we realized after the fact. And with the watch in the other condition, we did not track that as well. Since it was during the summertime, it was easier having them do the runs during that time, getting the natural hyperthermic effect of the summer. So we did not have that comparison, long story short, done.
Great. And then let's see, Dr. Cassidy asked, your study, excuse me, your study sample has a max VO2 level of approximately 17 METs. What's the average MET level for the average adult? Do you think the prediction would be better for individuals with a lower fitness level?
Thinking back to a couple of our studies that I did go through with the lower levels of VO2 max, we did kind of see in the different studies that it was a little bit better at predicting. I can't say for sure certain since I don't have those results in front of me though. But
okay, great. Dr. Schwartz said, did you look at any differences in groups based on training volume, like low mileage week versus a high mileage week?
I did not personally look at the differences there. It is something that I can go into with it since we should have that available within my data as well. So
And then Nicholas Voth, was there a relationship between temperature and magnitude of difference between VO2? VO2s.
Can you say that one again? Sorry.
Yeah, Nicholas, did you want to just say it, or maybe I didn't capture right? Was there a relationship between temperature and magnitude?
Was the difference between VO2s greater as temperature of the runs?
I actually I didn't really. Yeah, I did not see a trend similar to that. Just the hyperthermic environment itself. So, because we had people running in 80-degree weather to people running into about 100, and it was roughly about this same difference. So,
Thank you.
And then Dr. Snelly had a question. Has previous research had better accuracy without using the hyperthermic environment, or do they underpredict in general?
so there's a lot of mismatching results even without the hyperthermic environment. So we have actually almost every single study that I've seen involves an ideal condition for testing. And still finds that mismatching results. Some of them will find a significant difference either under or over predicting. There are some of them that won't find any significant difference, saying that they're pretty accurate what they're doing. There's a lot of mismatching results based on these watches.
Okay, well, good. Let me check to see if there's any other questions out there, but I think we are, oh, well, do this as our last one. Who would you recommend this product to? College athletes, average individual, professional athletes? Anyone?
So I would still recommend it to honestly any population that's going to be working with it. As a runner myself, I enjoy having the watch. Yes, I will take some of the results with a grain of salt, of course. But just having the data readily available, it just the convenience kind of outweighs the accuracy sometimes. Would I want it to be more accurate? Yes. Having that convenient factor though is pretty helpful with what I do. And even as someone who may not be as competitive, is just a pleasure runner or something like that, that VO2 max score and having that so easily available, it's an expensive, pretty lengthy test to do it without the watch or just in a typical environment. So having that convenience, although it may not be as accurate, is still very nice. So.
Okay. Well, thank you. Thank you, Anthony, for that great presentation and all the great questions from our audience. Congratulations. Anthony, if you can unshare your screen, that would be great. And then Erin, you are up now, so you can go ahead and share your screen. Oh, great. So our next presenter is Erin Hocker. She's a occupational therapy doctoral student. And Erin, did you graduate this weekend? Is that correct?
Yes, I did. Yep, okay. Very good graduate.
Yes, so she's a graduate, actually. She'll be talking about animal-assisted therapy for individuals with dementia, an occupational therapy perspective, and program protocol. So I will turn it over to Erin.
Okay, thank you, Dr. Putoff. So as he said, my project is titled Animal-Assisted Therapy for Individuals with Dementia, an occupational therapy perspective and program protocol. Let me go ahead and get this in presentation mode. And my mentor for this project was Dr. Brenda Hughes. So the population that I focused on for my project is people with dementia. So this could be due to Alzheimer's disease or another form of dementia. And currently we know that there are 5.7 million people in the United States with Alzheimer's disease. And this number is projected to grow to 14 million by the year 2050. So it's going to more than double in 30 years. We know that dementia is progressive. It cannot be cured. So symptoms are going to get worse over time. And so some of the common symptoms that we see in this population are what's known as the 4 A's of dementia. So that's agitation, aggression, anxiety, and apathy. And as you can imagine, these symptoms and behaviors create problems for the person in practically every area of daily life. But particularly what we look at as occupational therapists is how these behaviors impact their self-care routines, leisure, and social activities as well. And then in facility settings where you have nurses and CNAs who care for these people, these behaviors can also create problems for them as well. So the intervention I'm proposing is animal-assisted therapy, and this is defined as the skilled use of a certified therapy animal by a healthcare professional during an intervention that is designed to achieve the client's specific goals. So this is not just a visitor or a volunteer going in with their pet. This is a certified therapy animal that has gone through extensive training and temperament testing to be certified. So the research out there right now on how animal therapy can benefit people with dementia is very promising overall. Some of the most commonly cited benefits include reducing agitation and aggression. It has been known to improve ADL performance, so that's performance with those self-care tasks. It can increase social participation and verbal communication. It has been shown to promote physical activity, improve mood, reduce depression and anxiety. And then for some individuals in the mild stages of dementia, there's some evidence out there that animal interaction can improve cognition, and then it can also increase self-esteem. So my actual project that I developed based on this information, my doctoral project, consists of 3 components. So the bulk of the project was my animal-assisted therapy program protocol, and this is based on the cognitive disability model and Allen's cognitive levels, which I haven't really talked too much about, but basically this was a model developed back in 1985 by an occupational therapist by the name of Claudia Allen. And what she did was she categorized 6 different cognitive levels based on the person's ability to function in their environment. I then developed a screening tool to determine if the client is an appropriate candidate for animal-assisted therapy. And then I also made an educational flyer for facility administrators and clinicians, just outlining the benefits of animal-assisted therapy and some additional resources if they'd like to learn more about it. So going into more detail about my program protocol, so it's based on Allen's cognitive levels 1 through 5. Since at level 6, the person is essentially without cognitive impairment, so I excluded that one. It first outlines just a general step-by-step protocol for how to initially incorporate animals into therapy sessions. And then I go into each different cognitive level, starting with 1 and going through 5. And I include suggestions and examples of animal therapy treatment activities that are appropriate for someone functioning at that specific cognitive level. I include some rationales and tips for grading the activities. And then finally, I want to point out the activities of this program are twofold in their benefits. So they're meant to work on those sensory motor skills that we typically work on in occupational therapy, so balance, endurance, strength, and range of motion, but they're also meant to motivate the client and target those behavioral and psychological symptoms that I talked about earlier. This is just an example pulled straight from my program protocol. This is the activities that are appropriate for someone functioning at Allen's cognitive level 4, which is titled familiar activity. So at this stage, the person can use visual cues in their environment to effectively complete familiar activities that they've done their whole life. So some animal therapy activities that would be appropriate for them include things like petting or grooming the therapy animal. This can provide sensory input, it promotes upper body range of motion, and it could even translate to their own grooming and hygiene routines. For someone who is prone to wandering, they can walk with the therapy animal, and this will target functional ambulation, balance, endurance, strength. Another fun activity, playing fetch with the animal. This works on strength, coordination, range of motion. Feeding treats can work on fine motor skills and hand manipulation skills, things like that. And then finally, training and socializing with the therapy animal may be beneficial for clients who struggle with verbal communication, socialization, and the client actually receives feedback from the animal as they perform or do not perform the commands that they ask. The screening tool I developed, it's just a short 2-page tool, and it's titled the Occupational Therapist Client-Centered Animal Assisted Therapy Screen, or the OT-CATS for short. The purpose is basically just to determine if the client is a good candidate for animal-assisted therapy, because certainly not every client is. They may be allergic to animals, they may become fearful of them, they may just not like them. And so it just includes 3 sections with a few questions in each section. And one section is for the client's family to answer, or close friends who are familiar with the client's history. Another section is for formal caregivers, nurses and CNAs who help the client on a daily basis with their care routines. And then finally, there's a section for the client if they are able to answer. This is the educational flyer that I created. It just includes basically a lot of the information I've already talked about. So what is animal-assisted therapy? How can it help people with dementia? What can occupational therapy provide in this for this intervention? And then finally, I list some resources there if they would like to learn more about animal-assisted therapy. So I hope to disseminate this to administrators, clinicians, just to kind of get the word out there about animal-assisted therapy. And finally, I just wanted to mention how this project could be applied to occupational therapy practice. So it's my hope that the protocol and the program that I developed, as well as the screening tool, could actually be used in practice by occupational therapists and other clinicians who are interested in utilizing animal-assisted therapy. And I hope the dissemination of this information may encourage other clinicians and facility administrators to maybe attend workshops on animal-assisted therapy, learn more about it, because the research is out there. We just need to start putting it into practice. So those are my references. And thank you for listening. Let me know if you have any questions.
Okay, well, great job, Erin. That was very informative and very interesting. So we'll go ahead and open it up to questions that people have. Did you get feedback from clinicians and other occupational therapists about this, about the model and how they'd see it implemented?
Not yet. I've talked to a few. I just completed my capstone rotation in a memory care unit. And so I talked to my supervisor about my project, and you know, she was really excited about it. She was really on board because she was to get therapy animals to come into the facility because she's heard about the benefits as well. And so, of course, with all the COVID-19 stuff happening, we couldn't get that going right away. But the people I have talked to, you know, they agree with it. They're on board with it. And so we just need people now to go out there and put it into practice.
Great. We got a handful of questions that came through. I'm going to let your non-professors in the OT program, I'm going to ask the other questions first here. Could you talk about how, this is from Regina Matheson, how you envision measuring the effectiveness of AAT in this population if you were to carry this into a data collection phase?
Yeah, so there's several different assessment tools that could be used. A few I've looked into include like there's assessments that measure those actual symptoms. So agitation, aggression, one's called the Cohen-Mansfield Agitation Inventory. So it really depends on what the therapist wants to use animal-assisted therapy for, and then they can pick an assessment tool to measure that, whether it be ADL performance or if we're actually targeting those symptoms. Could be verbal communication, could be a lot of things, but there are definitely a lot of tools out there that can be used to measure.
Okay, great. Monica Ford asks, what type of training do OT professionals need to work with therapy animals?
Yeah, that's a good question. There's actually really no set standard by any governing body as far as how much training they need to have. So it's kind of going to be up to the company that they work for or the facility that they're using animal therapy at as far as how much training they need. But most places will probably want the person to have you know, a good amount of experience both handling a therapy animal as well as working with the dementia population. So they have to keep in mind things like infection control, safety procedures, reading the animal's body language, being able to tell if the person's behaviors are escalating in the presence of the animal. So they have to have a really just multifaceted knowledge of all these things that come into play and all the safety factors to consider. So yeah, no formal training as far as like years or certifications that you need. But yeah, just relevant experience is what most places are going to want.
Okay, great. And we have time for, I think, one more question here, and let's go with this one. Can you, and this is from Ann Lansing, can you discuss how billing might occur when using animal-assisted therapy interventions? And I think that ties into what it looks like in true practice too.
Billing, yeah. So basically, as long as the client has already had a referral for occupational therapy services, the therapist uses animal-assisted therapy at his or her discretion, and the animal is considered a modality. So it's reimbursed just like any other service that an occupational therapist could provide, as long as they clearly document the skilled use of the animal and why it's being used in therapy. So it's reimbursed just as other OT services.
Okay. Well, great. We're at our time for questions. There's some more in the chat that you can take a look at a little bit later, for sure. But thank you very much, Dr. Hocker.
Okay, thank you.
Okay, so Erin, if you will unshare your screen, please.
Oh, here it is.
And then Tyler, you can go ahead and share your screen if you will. There we go. Okay, so our next presenter is Tyler Meseke. He's a Master of Physician Assistant Studies student. And his project or his presentation today is, do physician assistants provide safe and adequate care to critically ill patients in the acute care setting? So please welcome Tyler.
Can you guys all hear me okay?
Yes, we hear you great.
Okay. All right, well, thank you, Mike. Like he said, my name is Tyler Meseke. I'm a second-year physician assistant student here at St. Ambrose University. For my master's capstone project, I conducted a literature review asking the question, do physician assistants provide safe and adequate care to critically ill patients in the acute care setting? So a little bit of background information on my topic. Right now, it is projected that by the year 2030, there will exist a shortage approximately between 40,000 and 120,000 or so total physicians. And the physician assistant or PA profession has often been considered as a viable solution to this problem due to our training in the medical model, which is sort of similar to that of our physician colleagues and mirrors that of medical school in a way. Traditionally, PAs have most often been employed in less acute settings, such as family practice, internal medicine, pediatrics, and geriatrics. However, as the PA profession expands and is incorporated into all medical specialties, the question of the safety and adequacy of PA practice in more acute and critical care settings remains largely unexplored. So the purpose of my research was to identify and review the literature on the quality and safety of care provided by PAs in the acute care setting, and understanding how PAs treat medically complex patients may provide us with useful information on how PAs may be more effectively and efficiently assimilated in a strained healthcare system. A little bit about how I carried out my research. I conducted systematic searches on the literature databases you see on the screen there. I tried to include all data that was published within the last 10 years or so, just to be as up to date as possible. And I included a total of 6 studies in my review. And I would just like to point out quick that 5 of the 6 studies are retrospective in design. So if you look at the right side of the screen there, what the researchers did in these studies is they would go back and look at admission data from patients that were admitted to either a team of just physicians or to a team with physicians and nurse practitioners and physician assistants. And the 2 most common patient outcome indicators they would look at are length of stay in the hospital and patient mortality rates. And then they would try and analyze whether or not that these outcome indicators were clinically similar or different between study groups. So now I'll just kind of summarize some of the key findings that the literature currently. 4 of the 6 studies compared the length of patients' admission to the hospital under either the physician team or the NP/PA team. 3 of the 4 studies found no clinically significant difference in hospital length of stay. However, 1 study did associate a longer length of stay in the hospital when admitted under the NP or PA team. And similarly, 5 of the 6 studies compared patient mortality rates between the physician-only team and the NP/PA team, and all such studies found no clinically significant difference in patient mortality. So now I'll kind of switch gears here and just talk about some of the limitations that I noticed in the literature. The first being this idea of unequal patient complexity. So right now, a lot of the literature sort of describes differences in the patient populations that are admitted to either group. Below is just a quick example of how one such study did that. They used what they called an acute physiology score, which is more or less just kind of how they quantified how sick or how acute a patient is. And the reason this is important is because, even if you have similar patient outcomes between each group, if one group is admitting much less sick or less acute patients, then it really starts to diminish the value in that finding of equal patient outcomes. And in fact, only 1 study that I reviewed found the patient mix to be statistically similar, and they just did that by what they called the mortality probability model. Next is the idea of relative PA involvement. So in the majority of studies, the PA staffed units had varying degrees of physician involvement, whether that be, physician staffed at all times, physicians only covering certain shifts like the night shift, or varying degrees of resident and fellow involvement as well. 1 study did, however, sort of define explicitly how involved or how not involved the physicians were. And they stated that patients were cared for continuously by the NP or PA throughout their admission, and care was never performed by a physician. And the issue here isn't that physicians were or were not involved. It's more just that the specific tasks and duties of the PAs were really poorly defined for the most part, which becomes especially evident in multi-center studies, because it's really difficult to say with any degree of certainty that PAs are utilized similarly among different hospital systems. And lastly, the other limitation that I noticed was the lack thereof additional outcome indicators. So all the studies I reviewed analyzed length of stay, patient mortality, or some looked at both as the primary outcome indicators. However, I would argue that these are relatively arbitrary measures of the quality of care that providers are giving. Just for example, the length of stay in a hospital a lot of the times is really just kind of decided from the patient. If they're more comfortable staying another day, they may choose to do so. Only 2 studies I looked at analyzed other clinically relevant quality of care indicators. I won't go and list them off all to you there, but the main point just being that the literature leaves out a lot of other useful indicators of quality care. So just to kind of wrap up here, the literature currently contains mostly retrospective analyses, and it fails to demonstrate a clinically significant difference in the care provided by PAs and physicians in the acute care setting. Thus, I think it can be said that incorporating PAs is both a safe and adequate alternative to physician-only staffing models. However, much of the literature lacks insight into the specific role tasks that PAs are performing, with the other limitations being establishing equal patient acuities between study groups and analyzing additional quality of care indicators outside of length of stay and patient mortality. And so the trend of retrospective analysis makes this additional insight difficult, which I think highlights the need for additional research in this area. And the main argument that I would make is that it should be in the form of, more prospective randomized controlled trials. That way you can sort of ensure that you equalize the patient mix between study groups, and then you can go ahead and clearly define or outline the specific tasks and duties that the PAs are performing. Here are my references, and thanks for listening, everyone.
Okay, great, Tyler. A lot of good information there, and I think something that we can all think about as we interact with different healthcare providers. So the first, okay, I got a couple questions here. Okay, was mortality rate measured the same way in all the studies? Many health systems benchmark on ratios of observed, sorry, it jumped on me, observed versus expected mortality to account for differences in patients.
Yeah, that's a good question. Most of the studies looked at just whether or not the patient survived their admission. So if they died in the hospital, a couple studies would follow up with the patient, say 30 days after they were discharged, or even as far out as 90 days. So no, they didn't measure mortality exactly the same, but I would say the most common way they would measure it was whether or not they survived the admission while they were there in the hospital.
Okay, great. Question about considering quality care indicators. Did the literature indicate patient satisfaction with care of PA care?
One study did, and they actually did rate their admission experience higher when a PA was involved on the care team. Just one study, I believe, though, looked at that.
Okay, then another question, based on what you can conclude, how would you move forward with advocating for one practice model over another? Would region where the clinic is located influence this recommendation or this conclusion?
Yeah, so the main point being here is, physician-only staffing models can become quite expensive. And so the main sort of argument here is that, hey, we have these other practitioners sort of trained similarly as physicians, and a lot of this review to kind of highlight, like, hey, the patients can still safely be cared for in a model where less physicians are staffed. Not to take away anything from physicians, of course, just that when physician assistants are working collaboratively with physicians, patients can still be adequately and safely cared for in perhaps a less expensive way.
Great. Another question about using the data that PAs deliver quality care in the ICU setting. How do you see the PA role evolving in this area?
Well, I would say in the specific context of the ICU, I would say the PA role could certainly be expanded to more rural areas where, a lot of times these hospitals are already sort of limited in their physician resources. So I think, I could imagine a situation where additional, let's say, postgraduate training programs or just training programs in general for new PA hires to teach them more advanced skills or procedures. That way, if you did send, a PA to a more rural or underserved area, they could perform a lot of the similar tasks and duties as a physician would.
Okay, great. I think that was our last question, and I think that, let me just check real quick. Okay, good. Well, I think this brings us to the end. So congratulations, Tyler. Great job on this.
Thank you.
Okay, Caitlin and Kelly, will you share your screens, please? Okay, so our next presentation is by two Doctor of Physical Therapy students, Caitlin Wright and Kelly Mikowski. They'll be talking about the application of a clinical practice guideline to improve locomotive function in patients with chronic stroke. So I'll turn it over to Caitlin and Kelly.
Thank you. Mike, did you unmute me? Okay,
Yeah, I did.
I was trying to figure out how
to.
Thank you very much. Okay, so thank you, Dr. Putoff, and good afternoon, everyone. This case report is on the application of a clinical practice guideline to improve locomotor function in a patient with chronic stroke, presented by myself and my classmate, Kelly Mikowski, And like Dr. Putoff said, we are second-year DPT students. So Kelly and I initially learned about high-intensity training for individuals with neurologic conditions in our neuromuscular therapeutics course, and that was with Dr. Nora Ridley last fall. I also learned more about this concept from a presentation on the clinical practice guideline to improve locomotor function following chronic stroke, incomplete spinal cord injury, and traumatic brain injury presented by George Hornby et al. And this was at the American Physical Therapy Association's combined section meeting of February of this year. The combined sections meeting was an awesome opportunity. It's a yearly conference where thousands of physical therapists, physical therapy assistants, physical therapy students from all around the world gather in one place for a week of education and networking. And this CPG that I went to the presentation of had reviewed randomized controlled trials with the goal of determining the efficacy of a number of different interventions in order to improve walking speed and distance in these specific patient populations. The recommendations from the CPG were determined based on the strength of the evidence, as well as any potential harm, risks, or costs of that specific intervention. Hornby et al. Found strong evidence indicating the use of task-specific walking training at moderate to high intensities, which was 60 to 80% of the patient's heart rate reserve, in order to improve those walking speeds and distances. This recommendation is level 1 quality and is based on 12 randomized controls trials, so it's very strong evidence for efficacy of this intervention.
So our patient was a 35-year-old male who presented to the St. Ambrose Interprofessional Health Clinic with right-sided weakness and general mobility deficits. He has a history of 5 cerebrovascular accidents or strokes due to an underlying congenital heart defect. He's highly motivated and had goals to walk independently and return to work as a mechanic. Based on his chronic history of neurologic events and the goal to walk, this patient fit the population for the clinical practice guideline that found benefit from high-intensity gait training. So to start, we found that this patient was unable to reach target heart rates and higher intensities of walking with overground gait training. So we implemented a treadmill so he was able to reach these goals. And we also used the slight gait harness system pictured here as a safety feature. To start our intervention, we had physician clearance due to his cardiovascular history, and we used a 3-lead EKG monitoring system, which found no abnormal heart rhythms throughout the session. We also put a small heel lift in his right shoe because he was in more plantar flexion, so he was up more on his toes to try and help minimize the amount of hyperextension he had during stance phase of gait. In order to calculate our target heart rate, we used 60% of his heart rate reserve, as Caitlin previously mentioned, and found that that was 145 beats per minute. To start his intervention, we used very slow speeds, which were his self-selected speeds because he could walk independently at these levels. Once we started to incrementally increase his speeds, he started to require more assistance of therapists. So he required moderate assistance of one therapist to help with hip flexion to help bring his leg up and clear it. During gait, he required assistance of a second therapist to manually move his foot and clear it and place it on the treadmill, as well as having verbal and visual cues in front to have him kick his foot to clear it, and then tactile or touching cues of his left leg to help initiate that step to have a more automatic reciprocal gait pattern. And with all of this, our patient was able to reach 1.1 miles per hour, and he did reach his target heart rate of 145 beats per minute for a very brief time. And this session in total was 45 minutes and 48 seconds.
So at the patient's second session with high-intensity gait training, just a week after his session with Kelly, we started by fitting him with a chest strap heart rate monitor. Since the EKG had been normal, we didn't feel the need to apply that for the second session. But with the heart rate monitor, we were able to constantly assess his heart rate throughout the session to determine when he hit that target of 145 beats per minute. His resting heart rate at the start of the session was 88 beats per minute. So next, the patient was fitted in the light gait harness and completed another independent warm-up on the treadmill like he had with Kelly. From there, we gradually progressed the speed of the treadmill to attain the patient's target heart rate, and at 1.6 miles per hour, this target was achieved. He was able to maintain this heart rate for a continuous 16 seconds before beginning to show signs of fatigue, and then the speed was decreased to 0.3 miles per hour to provide him with an independent active rest break for 2 minutes. After After the rest break, the speed was more quickly ramped back up to 1.6 miles per hour, and the patient achieved a heart rate at and above his target for 3 continuous minutes before showing signs of fatigue. His heart rate actually peaked during this time at 165 beats per minute before he underwent another active rest break. After that rest break, the speed was ramped back up again to 1.6 miles per hour, but just after a few seconds, he began to display severely declining gait quality and reported significant fatigue. So the intervention was terminated for the session at that time. Throughout this session, he again required moderate assistance for hip flexion and foot clearance of his right lower extremity during swing phase. He also required moderate assistance with step initiation of his left lower extremity this session once we got up to those higher speeds. And this was to decrease stance time on that left side and to normalize his stride length and the reciprocal gait pattern that Kelly had mentioned. Verbal cues were also used this session as well. In total, the patient had ambulated for 30 minutes on the treadmill, with about 3.5 of those minutes being at or above his target, which was a huge improvement just from the previous week. And unfortunately, this was the last session we were able to see the patient due to the COVID-19 pandemic.
To apply the CPG, we looked at some barriers, and one we noted were equipment requirements in terms of this patient required the treadmill to reach these higher speeds and intensities, and the light gait harness system for safety. Time constraints were another issue, so our interprofessional health clinic operates 1 time a week for 45 minutes. So this is the only time we were able to see the patient, whereas he would benefit from at least 3 days a week of closer to an hour's worth of training. Having to hook him into the harness and get him back out of the harness also took some time, which cut out the time during which we could have been walking at higher intensities. And we also found when this patient was able to reach his target heart rate, he began to fatigue more quickly, and so we were not able to walk with him for as long at the higher intensities. For a pro, this patient was a very young, highly motivated individual. He has been working out 7 days a week for 1 hour every day. We also found this specific CPG for locomotor training in patients who have previously had a stroke, which was really good. And then I have also had some previous experience on a clinical and inpatient rehab with a similar body weight support system for gait training and manual assistance of moving the right lower extremity through the phases of gait. For some cons, this is extremely recent evidence published this year, and so Caitlin and I both have very minimal experience in applying it. And because of the possibility of the cardiovascular event, we monitored it, and that's why we also noted it as a con.
So although CPGs are high-level evidence and can be a very informative resource in clinical practice, we recognize that clinicians need to treat them as just that, guidelines. We still need to adjust its application to best fit specific patient comorbidities, needs, preferences, and goals, as well as our own clinical experiences and judgment. Individualizing the treatment plan in this way can also help with patient buy-in, which is very beneficial to the therapeutic process, clinician-patient rapport, and subsequent outcomes. At the end of the day, our experience in applying a CPG was a positive one, I think both for us and our patient, and we look forward to taking the lessons we learned from this experience and applying them to more patients in our future practice. There are references, and we thank you for your time today. We will take questions.
Okay, well, thank you, Caitlin and Kelly, for this great application of a clinical practice guideline. We'll open it up to some questions for sure. What do you, Caitlin, I think you said you've done this in the past in other clinical settings, or is that Kelly? I forget which one of you said you did this. How close were you able to replicate? Yeah, how close, Kelly, were you able to replicate this in the health clinic?
I feel like I was able to pretty much replicate what I did because the previous patient I had seen also had a stroke that affected more of their right side. So in that session, I was down with the patient. I had a hand at the back of the knee and a hand kind of under the foot to help bend the knee and get the foot cleared and then place it back down. So it was pretty much the exact same thing that I had done on my clinical that I was helping this patient out with.
Great. There's a question from Taylor Swanson. How was the patient's attitude towards the light gait training? That's a big barrier, not a barrier, but a thing to consider. How did the patient feel about this?
Yeah, so like Kelly said, he was very motivated. very active both before and after his various neurologic assaults. And he was very open to letting us kind of work through this process. He was definitely patient with us as we tried to problem solve the different aspects of getting it to fit him specifically. And then he was a good sport when Lynn Frank, who helped us with this project, was kind of in his face, like, kick your foot, like as a motivational tool. So I think, yeah, he had a good attitude. He was fun with it.
And do you think, again, we're dealing with the COVID-19, but is this something you would recommend that he continue to do when the clinic opens back up?
Yeah, absolutely. Even that last session that we had seen him at the beginning of March, Lynn had reached out to, I think, his primary care and a local physical therapy clinic to him to recommend that he start treatments with them, even more than just coming to the IP clinic. So we're hoping that, that isn't lost in all this and he continues to benefit from this intervention.
Okay. Well, great. Thanks again, Caitlin and Kelly. You did a great job.
Thank you.
Okay. You'll see there's some further comments and some nice things in the comment bar there too. You can take a look at there. So Clarissa, I think yeah, you're here. Great. If you can go ahead and share your screen, that would be great. Okay, great. So our last presentation of the afternoon is Clarissa Thomas. She's a Master of Science in Speech Language Pathology student, and she'll be talking about progress monitoring of the effect of see the sound visual phonics on single word decoding skill acquisition. So I'll go ahead and turn it over to Clarissa.
Hi, thanks for having me. It's a great opportunity to get to share this research with all of you. I want to take a second to thank David Krupke and Dr. Knox, research advisors, and I just really appreciated their knowledge of the subject matter and their motivation and passion for finding out more about it. So I'm going to try to take the first few slides here and just kind of unpack this title. There's kind of a lot of moving components and background knowledge to this research, so I want to take a second to make sure everybody feels like they're comfortable with the subject matter. So the first thing that most people are probably pretty comfortable with is the concept of progress monitoring, and the method that we use to work are called curriculum-based measures. So curriculum-based measures are a little bit more unique than, let's say, like a pre-test, post-test, or like a criterion-based testing method, and that you're using materials from your instructional materials as the testing materials. So you know that you're testing the same things that you've taught. And this allowed us to look into all three phases of learning. So we're not just looking at did they acquire the skill, but is this skill staying with students, and are they able to generalize that skill to new opportunities, new settings where they might need that same skill. So curriculum-based measures aren't as commonly used, but they are still an accurate prediction of performance. Okay, and then I want to take a minute to talk about see the sound visual phonics. It's really familiar to speech language pathologists. A lot of speech language pathologists use this, but I realize it's probably unfamiliar for many people listening in. So basically, see the sound visual phonics is a gesture system that provides direct correspondence between sounds and gestures. Originally, this was developed for use with deaf and hard of hearing populations, and still predominantly it's special education settings, but it's being used more frequently in general education settings, especially in pre-K, kindergarten, and first grade. There's a lot of potential benefits to using this strategy with different students. I think probably the way that we saw it used most when we did observations was helping kids build that grapheme and sound. there's a lot of times in the English language, especially when you can spell the same sound differently. So if you think, for example, of shoe and chef, you still have that sh sound at the beginning of both words, but they're spelled differently. One is SH, one is CH. So that can be really tricky for a lot of kids as they're learning to read and write and just, developing those entry-level skills that's going to build the foundation for their reading. Okay, and then, so our research was in a first grade class, or 2 first grade classrooms. So we were looking at single word decoding. And really that's just being able to, decode what the word is. It's not necessarily, reading for comprehension or reading to learn, but this is the reading level that we're expecting graders to be at, just single word decoding. And really the skill that we want to make sure that they have down. For some people, you might be listening and thinking, well, single word decoding, that's such a huge deal? They're not reading to get information out of it. But it really is important. The reading levels of students at the end of first grade are reflected in their 4th grade level and across their educations. Getting in there early and addressing reading difficulties early on is really important. It's also important because as this becomes more quick for children, then it reduces their cognitive load when they are at a point where they're trying to read for comprehension and read for understanding. So I know it seems like, oh, single word decoding, but it's very important. Okay, and then just a little bit of information on evidence-based reading instruction. It might seem like we've been teaching people to read for so long, surely there's a curriculum that you can kind of just pull out and it's the best program and that's the best way to teach kids with reading, how to read. And, certainly the people producing these products would like you to believe that as well. It's really not that there's necessarily a best program or best pull-out curriculum that kids are going to learn to read by. But there certainly is a strong evidence base about what should be included in good evidence-based reading instruction. And one of the components of that is somatic phonics instruction. So visual phonics, or see the sound visual phonics, is definitely a way to help provide a systematic phonics instruction. And then this last bullet point might kind of seem obvious, that evidence-based practices should be easy and able to be used by teachers, but that is something that some people have said about visual phonics is they don't feel like they have all the ideas and resources of how to use it, because it's not necessarily a pull-out curriculum. It's a strategy that you can use within your teaching as you see fit. Okay, so those are kind of the wheelhouse of what this research is all about. And now let's kind of go more specific into this study that I completed with Dr. Knox and Dr. David Krupke. So we were looking at 2 different classrooms. One classroom, our experimental classroom, was taught by an experienced teacher who's trained in see the sound visual phonics and had been using see the sound visual phonics for many, many years. And the other classroom was also taught by a very experienced teacher, but she was trained in see the sound phonics and she did not use it in any of her teaching. So we looked at both of these classrooms, and the kids in both of these classrooms were randomly distributed into both of those. We had no, say into what who went where. And so we were curious, one classroom has this extra strategy that's being taught and one classroom doesn't. How does it impact their single word decoding? So that was kind of one big question. And then the other question that kind of went with it was, we're using these curriculum-based measures. We're using a method of probing and progress monitoring that's allowing us to look at all 3 phases of learning. So what are the differences with each phase? What's the difference with acquisition, maintenance, with generalization? So that's kind of the setup for this research. We have one experimental classroom, one control classroom. So the probes were administered weekly. Acquisition probes were administered every single week, and basically they were words pulled from the spelling list, but they were mirror words. So they weren't the exact same word, but they still had the same sounds and writing, spelling patterns that were being taught that week. So it was testing exactly what was being instructed. Then the maintenance probes were seeing, what children retained a week later. So those were given the week after. And then the generalization probes were looking ahead. Could kids use this strategy that they'd already been taught to decode something that they haven't taught yet? So there's these 3 probes. Students in both classrooms were getting them the same day. They were being administered by the same probe administrator. And we had the opportunity to go up and observe several times, and we felt like all the probe administrators and the teachers had good fidelity. Okay, so I wanted to just kind of jump into some of the results. The first thing that we compared was the experimental classroom versus the control classroom, just as a whole, the whole classroom. And really, when you compared the whole classroom, there wasn't striking differences. The experimental classroom performed very similar to the control classroom. So then we kind of looked at, okay, let's look at the gender differences for the experimental versus control. Did see the sound, visual, phonics make a difference for certain genders? And once again, there wasn't any significant differences. There were differences, but not necessarily significant differences. So next we were looking at literacy group. All the students in both classrooms were divided into 4 literacy groups, advanced, and then 2 kind of middle ground reading groups, and then a more intensive reading group. So what we noticed was that the students in that advanced reading group really didn't seem to have a staggering difference between if they were in the experimental classroom or if they were in the control classroom. It seemed like they already kind of had their strategy down on how they were going to decode a word, and whether or not you gave them a new strategy or not, it didn't seem to make a huge difference for them. But for those 2 middle reading groups, it seemed like it made a big difference for the kids in the experimental classroom. Seemed to have a much stronger benefit from having that additional strategy available to them. And then the last thing that we looked
Clarissa,
at.
you have about 30 seconds left, just to let you know. You have about 30 seconds left.
Okay, was second try. So all kids were given a second try to see if that made a difference, and the experimental classroom seemed to help them. And then I just wanted to mention that the intensive reading group really did seem to change the data quite a bit. When you excluded the intensive data, the group from the intensive reading group, it really changed the mean values, and there was more significant differences. The blue indicates the experimental group, and so you can see that that reading group really changed the results pretty drastically. Thank you guys for the opportunity to share with you the research.
Okay, great, Clarissa. That was wonderful, and some very interesting ways in which you go about teaching reading. So let's go ahead and open it up to questions. So based on what you talked about here, how do you see this transferring into your practice as a future speech language pathologist?
I think that one of the big things is how powerful it is for us to collaborate with teachers. I think that getting a chance to talk to teachers and see the struggles that they're up against with not only the expectations of what they're supposed to be taught, but the access they have to kind of modify their teaching style is sometimes kind of limited. We were fortunate to somebody who'd been using visual phonics for a very long time, and you know, one of the reasons this research is really important is there's not gobs and gobs of evidence out there saying that visual phonics works in a general education setting. So it really does need a stronger evidence base. So when teachers come to the plate, they can say, you know, there's a ton of evidence that this works. Can we pay for trainings? Can we get people trained in this? So, you know, it's really being able to work with your teachers and be a support system for them, because they get more hours in a day than the speech therapists.
Okay, wonderful. We have a question about if you could do another study on this topic, how would you change the design?
You know, I don't know that we would change the design per se. I think it was designed pretty well. I think really what needs to happen, and that's the, you know, the aim, Dr. Knox and David Krupke, is to keep getting more of these studies completed. This study was completed at maybe, like you'd say, a mid-range socioeconomic school. And so the distribution of students with advanced versus intensive reading groups, you know, was pretty spread across the board, with there actually being fewer students in those intensive reading groups. That would probably change if you were in a lower socioeconomic region. And so you might see different results, especially since we found that the results were so varied in that intensive reading group. And I think really that's just because you don't know why someone's in that intensive reading group. You don't know if it's lack of exposure. You don't know if there's some underlying condition, you know, that hasn't been diagnosed. And really, when you think of kids who have maybe some attention deficits, having that additional visual cue may or may not help them. So I think it's important to keep in mind that See the Sound visual phonics is a great strategy, but it's not a one-size-fits-all prescription.
Okay, great. We have time for one last question here. So how does this mesh with classrooms using balanced literacy versus structured literacy? Would one anticipate pushback from those supporting and trained in a balanced literacy mode?
You know, I think that really you can incorporate See the Sound visual phonics into any literacy instruction. It's not necessarily needs to be excluded in any way. It's really just another way of drawing attention to that sound grapheme connection. So I don't think that it necessarily would need to be excluded in any, you know, existing literacy instruction. And there's certainly, you know, people who are wonderful teachers who don't use this strategy. It's another tool that might help some specific students. And like I said, you know, not every kid's going to benefit from it the same way, but for some kids, that might be a big breakthrough for them.
Okay, well, great. Well, great job, Clarissa. We enjoyed hearing that talk and great answers. So congratulations.
Thank you.
Okay. Well, again, thanks to all our presenters. You all did a great job, and I was really impressed when I read all your abstracts, and even more impressed after hearing your presentations. Later this week, I'll send out an announcement to our graduate faculty and students announcing the awards for our presenters, so be on the lookout for that. Also know that I recorded this presentation and we'll make it available on YouTube in the near future. I want to say a special thanks to the members of the Graduate Scholars Conference Planning Team, Mike Cipriano, Nicole Pizzini, and Rhiannon Sinelli. They provided a lot of input and oversight and planning when it came to the event, reviewing submissions and promoting this event. And then thank you to our judges, Monica Foret, Professor in College of Business, Sandy Cassidy, Dean of the College of Health and Human Services and Professor in the College, and Regina Matheson, Professor in the College of Arts and Science, and also the Associate Vice President for Academic Grants and Sponsored Programs. We appreciate their feedback. Once again, thanks again for attending the event. We were glad you could be here, and this brings our event to a close. Have a great day, everybody.